on my phone here, so we'll go ahead and get started. Thank you everyone for attending today's webinar on telehealth triage, how to use telehealth during COVID-19. This is being put on by the Coalition, California Telehealth Policy Coalition. My name is May Kwong, the Executive Director at the Center for Connected Health Policy. Next slide, please. The coalition is a collaborative effort over 70 statewide organizations and individuals who meet monthly to discuss emerging telehealth policy issues in California and identify cooperative means of advancing California telehealth policy. The group was established in 2011 when AB 415, the Telehealth Advancement Act, was introduced and continues as telehealth becomes more integral in the delivery of health services in California. Convened by CCHP, the coalition's membership is a diversity of organization that reflects telehealth's potential scope and reach that it can have on health and well-being of the state's population. Through the collaboration of the group's diverse members, the coalition aims to create a better landscape for healthcare access, care coordination, and reimbursement through and for telehealth. Next slide, please. So the purpose of today's webinar and key objectives that we hope to achieve is to really educate stakeholders on telehealth basics and how it can be used for triage and treatment during COVID-19. Specifically, we hope to share caregiver, patient, and provider perspectives on how telehealth can facilitate care delivery, particularly during the COVID-19 pandemic, increase attendee interest in using telehealth to meet patient, health plan member, and other constituent needs, and enhance attendee knowledge of telehealth modalities, use cases, and key considerations. So for today's agenda, our webinar will begin with a brief overview of telehealth, just to make sure everybody is on the same page. Then I'll hand it off to our panelists, and you have a great list of panelists who will be speaking to you today from both the perspective of the caregiver, the patient, and the provider on how to use telehealth right now during COVID-19. Please note that the attendees will be muted throughout the webinar. If you have any questions, please submit them through the Q&A button, not the chat box. So we ask that all questions be submitted through Q&A and not the chat box. And we will have them sent to our panelists during the Q&A portion of our webinar. Next slide, please. So I just wanted to say that there are several fact sheets that the coalition has prepared to go along with the materials, go along with the presentations today. These will be available on the coalition's website. You can access them and download them, and also let you know that this session today will be recorded and also posted later if you want to revisit it or if you want to share the recording with others. Next slide, please. I would also like to take a moment to thank our sponsors for today's webinar, the California Healthcare Foundation, AARP California, and a national consortium of telehealth research centers. So we thank them greatly for their continued support of the work here in California, as well as in telehealth in general. So to start with, what is telehealth? Just a few sort of basics here, just again to make sure everybody is on the same page. Some of this may be familiar to folks, but really we're looking at telehealth as a way to do a couple of things, is to increase access to specialists, improve patient-centered care, and reduce specialty referrals. And the way we do this is through two means, like a real-time means, which is called synchronous, or a non-real-time means called asynchronous, which is something that some of you may be familiar on the terminology. So synchronous, the one that most people are familiar with is live video, which is what we're doing now. It's a real-time interaction over video between the patient and provider or between two providers. And asynchronous is a non-real-time interaction where information is captured or stored and then it's sent to a provider to be looked at a later time, sometimes referred to as store and forward. There's other ways of also providing it and using these modalities as well. So there's not only can the live video option be between two providers or between a provider and the patient when they're in clinic, but it also could be directly to the patient when they're in a different location, so a direct to consumer type of interaction. For the asynchronous version, it can also be a continuous monitoring of a patient, which is called remote patient monitoring. So say, for example, you have a condition that requires sort of daily readings being sent to your provider, such as you have high blood pressure and they want to keep an eye on your blood pressure readings daily. you take your blood pressure readings and you send them to the provider who looks at it at a later time, perhaps at the end of the week or the end of the day. So it's a continuous monitoring, but not necessarily a real-time monitoring. Also, telehealth could be used on educational purposes as well. So distance learning, you can involve a series of providers together to discuss a case. It's an ECHO model, what some people refer to as ECHO, another term that some of you may have heard, where a case is brought before a series of panel of specialists, and they discuss that particular case and provide recommendations back to the provider who presented the case to them, usually a primary care provider. You also have a non-real-time version of that as well. In some respects, it's called e-consult, and that is a consultation between two providers, where usually a primary care provider, but not necessarily having to be a primary care provider, sends a case over to a specialist who looks it over, provides their feedback on it, and sends the information or consults with the primary care provider and how to care for the patient. And then care stays with that primary care provider or that original provider. So these are some of the ways that technology is being used to provide health services and care through telehealth. Next slide, please. So we're going to start off with our patient and caregiver perspective here. So I want to introduce our speakers. First up, we have Ginger Moyles, who lives in Etna in Siskiyou County, just south of the Oregon border. Ginger has adopted a special girl with very rare syndrome who's been treated by multiple specialists at UC Davis. And we'll also hear from Julie Bates, who is an Associate State Director for AARP with matrix responsibility for telehealth, local advocacy, long-term care services, and supports the greater Sacramento area. So we'll turn it over now to first Ginger, and then we'll hear from Julie. Ginger, I think you're on mute. So.
Hey, I'm not muted. Hi.
There you go.
Hi, I'm Ginger, and I do live just south of the Oregon border in California, and I travel very frequently to UC Davis for my daughter's medical care. I adopted her as a single parent in 2011 out of foster care, but she came into my home and my heart when she was 2.5 months old. I've taken care of all of her medical needs since that time, and she was genetically confirmed in 2014 with Spritz-Goldberg syndrome, which is a rare connective tissue disorder. So I travel from here is a 4.5-hour drive from here to UC Davis if I don't stop. I've never done a one-day doctor's appointment down and back in under 12 hours. I average about 25 appointments a year to Sacramento. I do about 5 appointments to Redding, which is about 2.5 hours away. And then I go to Medford, Oregon once a year for an appointment. That's for her specialty care. Depending on the type of appointment and the time of day of the appointment, sometimes we stay in a hotel or Kwong's house. But due to her behaviors and her fear of going to the doctor, she's incompliant most of the time. And most of these appointments is just me talking with the doctor and exchanging informations and sometimes her check over. Most of her issues are internal, and they require lots of tests. They do x-rays, MRIs, CT scans, and monitor things as her body reacts from the inside mostly. So in January 2018 was my first experience with telehealth. Her neurologist suggested that we try it for our in-between hands-on appointments. So I traveled to Fairchild Medical Center, which is about 45 miles from my home, where the nurse there did her vitals, and they took notes during that appointment with her primary care doctor present. And we've done that for about 8 appointments since 2018 when we started doing that, which has been really nice to not have to travel to UC Davis for a long day just for a quick how we doing med check appointment. When he does need a hands-on, then we drive on down to Sacramento. That's the only doctor that we've had telehealth with before the COVID-19 events. Since then, we've had 1 appointment with that doctor, and another doctor also, and we've only had 3 appointments this year so far due to things being rescheduled. I do have 5 appointments scheduled in May if we go back to normal. And 2 of those are going to be via telehealth, and they're with 2 different doctors that I haven't used telehealth with. So I think that's a great option as a parent. I have a friend up here also that travels to UCSF with a daughter with cystinosis. She travels in 2 days. She cannot do a down and back due to excessive water intake due to the disease, multiple feedings and medications through a G-tube, and then multiple potty stops due to the disease. I have another young mother that I advocate for up here that has a severe CP baby, and has seizures, and we haven't figured out a car seat for her travel. So she hasn't been able to travel without the baby seizing all the way to UC Davis. So telehealth is a great option when you're traveling this far with some of these conditions. Since COVID-19, the more normal world, I call it, has been utilizing telehealth more frequently, and I'm hopefully finding it very useful. But for someone like us with medically complex medical children, it's something we've talked about and wanted for years. And I hope this practice stays a viable option for us. Also, as a parent advocate in my county, I try to look at both sides of this, from the patient and the provider. And I really hope the insurance companies make this a good billable option for the providers, so they see it as a good option also. They require me to drive the 12 hours so they can see my child, but they also need to get paid for their time. If they can get paid for their time and I still get my information, everybody wins. We're a really rural area, and we have some low-income families here that don't have travel. So even with partnership offering travel reimbursements or transportation being done for them, that's an expense that's not always necessary if it's not a hands-on required appointment. I am all for the traveling when it's needed. I go to UC Davis down in May for an EEG, an MRI, and a CT. And then I was scheduled for a follow-up with her vascular surgeon for the results of the CT for her abdomen. I asked them if we could do it by a video visit, which is what UC Davis calls it. And they said, yeah, we could. They didn't offer it initially, but because I asked, they said we could, because they were just giving me the results of a follow-up test. It is not an initial test. So they're not really going to be new results for me. So I think that's a great option. She fights going to the doctor, getting height and weight. I get distracted. I don't remember what I wanted to ask the doctor. And we don't get to sit down and talk about the real needs when you have a child that's acting up in the room. But doing it at home, I can be more focused on my conversation with the doctor, get it done, get it over with, and everybody goes about their day. The doctor can go back to their next patient. As long as they get paid for giving me my time and information, I'm happy. I got everything I needed, and I didn't have to sit in the car for 12 hours. I think it's a great, great thing. My fear with it is that people may use it as it's too convenient, and I want to make sure everybody is getting seen and hands-on when they need it. We're using it for some therapies up in this area at our local hospital, which is great for some reasons and not for some others. But in the future, as we pass COVID-19 and get out of this whole pandemic, I would love to see this as a viable option for some visits and keep this open besides just the COVID-19. It's very useful as a parent with a medically complex child. So I appreciate this, and I hope that there's checks and balances and everybody can make this work out for the benefit of me as the patient parent and for the providers, that this is a viable option to continue in the future. Thank you.
Thank you, Ginger, for sharing your story. Julie?
Well, Ginger, you certainly bring together children and the older adults. And, I will tell you that we at AARP are very much working hard and diligently to ensure that these newly offered benefits will continue as time goes on. And for those of you who don't know, AARP is a nonprofit, nonpartisan membership organization, and we've been working hard to promote the health and well-being of older adults for more than 60 years. In the face of this crisis, we're providing information and resources to help older adults and those caring for them to protect themselves from the virus and prevent its spread to others while taking care of themselves. All the resources that I'll be covering today are located on our website, and you can go there at aarp.org or to our coronavirus specific website, which is aarp.org/coronavirus. And there's a lot of information there, including, which we'll talk about shortly, tip sheets for participants or for members that will hopefully help you serve your patients better as you go through implementing telehealth for providing care. So we're providing the information and resources to help older adults and those caring for, if I could talk, caring for them via modalities like this. Last week we had our coronavirus teletown hall that's targeted and was specific to telehealth. And like many things, when talking about technology, there needs to be some kind of technical problem. And we did have a little bit of technical difficulties during our teletown hall. And that actually was a beneficial thing. We had more than 76,000 members on the line for an hour to hear about how to utilize telehealth through Medicare, private insurance, and other modalities, but also to help people learn how to prepare for their visit. And one of the things we inform them of and remind everyone always is technical difficulties can in fact happen, but if you're prepared, it's easier to maneuver them and to handle them during a telehealth visit. This teletown hall is available for you if you want to listen to it or to read the transcripts. And you can see we have one of the benefits of AARP being the largest membership organization for the older adults is we tend to be able to get some pretty nice experts to join us on town halls like this. And so we had the Chief Clinical Officer for the National Health Information Technology. We had the Senior Vice President of the Henry J. Kaiser Foundation and the others that are listed here on this slide. And again, you can go to aarp.org and there'll be a list at the end of links that you can go and listen to or read these transcripts. And so let's talk about what's happened in regards to COVID-19. And like Ginger was mentioning, we anticipate, we AARP, the unintended consequence of the exponential growth of the utilization of telehealth will continue after this crisis is over. The light speed in which CMS, or the Centers for Medicare and Medicaid Services, and others have been able to pivot to pay for and cover telehealth has been extraordinary. Sure, we might want it to have gone faster, but in the greater scheme of things, in organizations that can often take years to change policy, that they were able to change coverage and access to telehealth in a matter of weeks is truly phenomenal. And we anticipate and expect that many of these advances will continue. So now the centers, CMS, Medicare and Medi-Cal are both providing coverage for telehealth services. And we expect that to continue. We're seeing it for mental health services, counseling, common office visits, and preventive health screenings. These are things that Ginger will be able to benefit from for her daughter, as well I will for my wife who is recovering from brain cancer. Or if my mother needed to see her health provider, I could do this through the telehealth modalities that have been approved for payment over this crisis time. There were 3 barriers that impacted the lack of adoption, and that was, or slowed the adoption before the pandemic hit, and that was the cost of sure. The platforms, in order to make telehealth reality, which you'll hear about shortly from some of our other presenters, the lack of insurance coverage, and others. And so these are things that we're seeing changed. We've seen a huge increase. There's been a increase of more than 50% in the utilization of telehealth just in March. And some of the providers like Teladoc and others have seen more than 15,000 telehealth visits per day. That is a mind-boggling amount, and we're hopeful that many of you on the line who this may be new for in providing care will see this as a good risk to take, because we truly do believe that this is going to continue after the pandemic is over. But one of the things you're going to have to do is prepare people for their visit. You know, we sometimes have a preconceived idea that older adults are technologically illiterate, and that can be true. There are a good portion of our 50 plus who don't have a smartphone and barely have a computer in their home. But there are an awful lot of the 50 plus that are as tech savvy as your teenager. You know, I use my mother as an example frequently. She will be 85 in June, and this Christmas she bought herself her own iPad. And she uses it for most everything, including having happy hour with her friends during this COVID-19 crisis. So you need to be sure that you are providing clear instructions, not just to the 50 plus, but to any patient that you might have on what to expect in advance of the visit. So if you have a patient portal that you've got to be logged in and do your paperwork before the visit begins, you need to tell them that before, and you need to give clear and concise instructions on how to do it. Don't assume that they know how. Don't assume that they don't need help, but don't be condescending either. Make sure that they are tech ready. Make sure that they have a smartphone with a camera, or that they have a laptop laptop like I'm using now to talk to you, so that they can see you and you can see them clearly. Also tell them what they need. You know, if Ginger's able to work with her daughter to get her weight and her height and her vitals, same things my mom would need to be providing, tell them in advance so they can have all of that on wait for you. They can have their glucose numbers if we're checking for diabetes. They can have any of the blood pressure, any of the tests that they are doing and monitoring at home on a regular basis, so that it is ready for them to give the vitals to you or to your staff person when they start the visit. And also just remember that anything that you want the person to be prepared for to tell you, tell them that's what they need to give, because most people are wanting to have a meaningful appointment with you. And if you tell them what to expect, what to provide, and that just like in the doctor's office, you might be running late by seeing another patient before, tell them that as well. Most of this is new. Telehealth is new for everybody for the most part. So make sure that people know and understand. Give yourself permission by telling them in advance that there may be some glitches, and just to breathe through it. And by the time this is over, it will be old hat for most people. And this technology will continue as we move on. And as I stated at the beginning of my portion, there is a ton of resources available for you at AARP.org. There's so much information that even I can get lost in finding what I want. So here on this slide are three specific resources that we provided to our members, and anyone could go to AARP.org and have access to this. There's also the link for the town hall if you want to hear it. Every single Thursday during the crisis, AARP is doing a COVID-19 teletown hall. Anyone can call in and listen and hear the information that we're sharing at any time. And then the other benefit that you have is, because I've participated on this with the coalition, you even have access to me. So if there are questions that you have that I have been unable to answer or that we can't get to today, you know how to reach out to me as well. I hope you found this information useful for you, and I look forward to learning with the rest of you from our other speakers.
Thank you, Julie, and thank you once again, Ginger. We're going to hold off on questions and wait until the end so all of our panelists can had a chance to present. So we're going to move on to the practice perspective. And our first speaker is Sean Johnson. I'm actually going to give all the speakers' bios so we can transition to them very quickly. Mr. Johnson is a healthcare information technology leader with over 20 years of professional experience. Sean spent his initial 4 years as a clinician and manager in oncology, inpatient and outpatient settings. And with intention, he transitioned to information technology to understand how systems and data can be used to improve care. Next 16 years have been spent leading the implementation and support for EHRs and business intelligence system. Earlier this year, Sean took the opportunity to become an adjunct professor at the University of Southern California for the MHA program, and the program focuses on policy and regulatory impacts in healthcare. Then we'll also hear from Dr. Kate Williamson, who is a pediatrician in Orange County and the president of the American Academy of Pediatrics Orange County chapter. She is also the chief informaticist of the CHOC Children's Hospital Primary Care Network, comprising 10 pediatric practices, where she recently led the integration of telehealth last month in response to the COVID-19 pandemic. And last but not least, we'll also hear from Dr. Misty Humphries, who specializes in open vascular and advanced endovascular treatment for arterial and venous disease. Her primary clinic interest is in the thoracic outlet syndrome and treatment of complex peripheral artery disease. She is a leader in health outcomes research and is currently researching how telehealth can be expanded to treat patients with vascular conditions. Her research is NIH funded, and this has provided her the opportunity to speak on national and international levels about the use of advanced endovascular interventions for critical limb ischemia, the increasing number of patients who undergo limb loss due to diabetes and arterial disease, and how telehealth can increase outreach for rural and underserved patients. So basically, we've got a bunch of smart people who are going to be talking to you about their specialties, and I'll hand it over to Sean.
Hi, thank you very much, May. Can you hear me okay?
Yes.
Great, just wanted to be sure. Just a couple things to follow up on. First, I want to say, Ginger, your daughter's beautiful, and she's lucky to have an advocate like that. And then also, Julie, when you're talking about some of the ageist ideas about some of the elderly not being able to use technology, our average patient using our patient portal is 80. So we actually do have quite a bit of experience. And then lastly, I've been personally training a lot of physicians on how to use telemedicine. And one of our young neurologists, this young gal, she looked at me and she says, okay, just know this, I'm a geriatric millennial. So it's all over the map in terms of, people's skill sets and trying to figure out like what are going to be the moments of how someone will learn, or some of the key things to do. Real quickly about Sansum Clinic, because most of you probably never heard of us. We are the last surviving independent medical group in California. So we're one of the last men standing. Most other health groups, healthcare provider groups, have been bought up by hospitals or affiliated closely. We're not. We're still fully independent. We are about 20 locations in the central California area, so between Carpinteria all the way up to Santa Maria area, with most of our work here in Santa Barbara. We are about 220 providers. 40 of them are advanced practice, the rest are physicians, and we're a multi-specialty practice, meaning about 50, 60 of my providers are primary care, with the rest being sprinklings of just about every specialty you can imagine. We have some pediatrics. We have a pediatrics for primary care, very few pediatric specialists, mainly because of the area and the lower volume of those specialties. Last thing I want to share before we go to the slides is a lot of my slides are going to have data. And what's really funny, if you had asked me 44 days ago what I might be talking about, it would have been about the fact that on March 2nd, I replaced our entire revenue cycle here at the clinic, which for those who don't know what that means, it's everything that makes the engine run. It's sort of like that trick where someone takes the tablecloth and pulls out from the table and all the dishes stay on. We replaced scheduling, registration, billing, and that we did that on March 2nd. And then I did something else on March 13th. So first slide. So this is just a little bit of a timeline about how we had the stop, drop, and roll in terms of what it meant to help us take care of the patients in the community. So on March 13th, the same day of the governors of the state of California's announcements of going into more quarantine and the idea of avoiding elective procedures, we started the process of canceling clinics. Now, patients were already beginning to cancel going into this week as well, but you'll notice with some of the slides I show later on, you'll see how the drop-off was precipitous in terms of patients showing up to the organization. On the 15th, just a couple days later, we were meeting a friend of mine over the weekend, and at this point, we hadn't received any clarity. The decision to reimburse for a full office visit via telehealth hadn't been decided yet or even communicated. So we were building out the guidelines for standard telehealth, which were old rules and very minimal revenue attached to those for providers, but we knew we had to offer something. So we started that infrastructure work on the 15th. I also went ahead and I was able to create an email distribution list of all of our physicians who had never used Zoom before, which we're using today. And I actually did an import of about 350 different providers. So not only our physicians or PAs, occupational therapists, physical therapists, respiratory, and imported them all in the system to get them ready for the next step, which would be how to have true telehealth other than just being using just a phone. At that point on the 17th, we actually went live with what we're calling Telehealth 1.0. And really it was two separate things. We had the electronic health record where physicians could document, they could see information on the patient, and then they would also just schedule independently in Zoom. The staff, we actually made it to where staff knew the provider's password for Zoom so they could coordinate and schedule the meetings for the patient, as well as help the patients get on board with it. That was the first part. We then, that exact same week, we called Zoom and said, we actually need to get this integrated into our electronic health record through the patient portal. Because the idea was, rather than me telling staff and patients to manage two things and two schedules, couldn't we just use the patient portal? And couldn't the patient just click on a start video visit button? So on the 31st, we actually went live with what we call our 2.0, which was, we went live with our full MyChart Zoom integration. Currently in our clinic, we have about 77% of all of our patients who come to the clinic are live on the patient portal, which is better than a lot of organizations, not as good as maybe a couple, but we're up there in terms of our availability of being able to take advantage of having an electronic health record with the portal. And as I mentioned earlier, the average age of our patient portal user, we already knew that we could help. If they know how to get on the portal, we can help them get into the telehealth visit a lot easier. We actually are, for the non-MyChart, the non-portal patients, they still have that separate Zoom schedule, and you'll notice we're fixing that very soon. So there's still a little bit of a hybrid workflow out in the clinics. We then, on the 13th of April, we revamped our text messaging system. So that's also coming from electronic health record. We encourage and we send patients links to do a Zoom test before the actual appointment. We give them phone numbers to call and links to a website where we give instructions on how to prepare for the visit. We are also just now starting on a pilot group, which falls into some of the conversation that I believe that May you were talking about, is we're going to actually have a patient support group where actually we're going to try to schedule for patients we think will struggle, for first-time patients, schedule a test on video visits so they can go through the motions once and at least feel successful, so that we have the opportunity before the visit happens to let the provider know, will Zoom work? And if not, can they use Doximity, which is another tool that providers like, or do they just need to make a phone call and make the best of it? Because if we can take care of that before the visit, we think we'll be much more, we'll be more successful than we have been already. And then on the 28th, we're actually, we've created a feature inside of our electronic health record for the non-portal patients, where all providers and staff are going to have to do is copy a button. They'll click a button which copies it to their clipboard. They can go to their email system or to our text messaging system and send the patients a link directly to get into the Zoom, into the secure Zoom video visit. Because our goal is to move away from the earlier Zoom basic accounts, because even though the government gave us waivers, we don't think those waivers will last forever, and we need to figure out how to make it always secure and something we can continue to do for years to come. Next slide. So I'm a data guy, so I like to pull the numbers because it just makes me feel like there's something objective in the madness that we're doing right now. So this is just by week, the number of telehealth visits that we've had. And you can see that our very first week, when I mentioned we had this really hodgepodge way, we went from 683, and then last week we had 3,413. And so then the question we're beginning to ask, have we saturated where we're going to be? And we'll talk a little bit more about what are some of those ideas as we go forward. But the rapid adoption has been really encouraging, both from a patient's perspective and our provider's perspective. Now, it is important to note that some organizations where physicians may be salaried may not have the same level of adoption, but they may have more authority to actually have providers do a certain amount. We're entirely, the providers are paid based upon the volume that they see. So their entire paycheck is based upon, do they have work to do? So there is some motivation there just based upon the fact that even though they can't see what they are financially driven to the fact that they still have a mortgage to pay and we still have patients that need care. And how do we keep both safe? Next slide. This is just one that I found interesting because when we saw the visits decrease last week, the question I had was, well, why? And so this just shows you the number of unique providers, which is the big blue bar going up. That's the number of unique doctors who came into the system that week. And then the green line, that's the average number of visits per provider that week. And so you can see on March 21st, I had 110 unique people that did 6.7 visits apiece. And then as you get over to the week of April 11th, that number, I had 187 providers log into the system and do at least one telehealth visit, and they did about 19.8 apiece. And so last week, the only reason we really had a downturn was I only had 184 providers doing the work. So that made me realize it really wasn't anything more than the fact that we're still hitting about that 20 per week per provider, which we think is low. We think we can do better. But we actually feel better that at least we know that participation didn't decrease, nor did the apparent demand decrease. Next slide. This is just some of the departments, and I'll probably have to explain what some of the abbreviations mean. I didn't have time to clean this up more, but we're always curious about who's really doing this, who's going to be able to use this the most. And so a lot of these you group together as one specialty, and I'll explain that as I go down. But the top one is endocrinology. And they're actually telling me that they think they can do everything almost forever via telehealth. Now, that's not quite true. There are some thyroid treatments and some things that have to be done in the office, but for the most part, they actually can do a lot of their care via reviewing the lab work, reviewing coaching, education with the patients, check-ins. They actually can do a lot very successfully. Pediatrics they were by far the first people out the gate saying, we don't need to see most kiddos coming in the office. They don't need to be in, which really accounts for what Ginger is saying too, is that this idea that the majority of what I need to do, sometimes that physical assessment is absolutely warranted, but a lot of it, if I've seen you and I know you and I'm following up on care, I can provide a lot of the guidance and I can even make the decision if you need to come in. We've even started to do some of the post-delivery weight checks over telehealth video too, and if the patient has the right type of scale. And if there's any concerns, we bring the patient in during certain hours of the day. Psychiatry, the only thing that they're upset about is that the regulation by Medicare still tells them they have to use video if they want to do a full visit. They're doing just about everything via telehealth, and that's a perfect example of an area where they can benefit widely from this, and patients too. The next one, you get down to all primary care. So when you get to internal medicine Pueblo, family country clinic, family Goleta, internal medicine Posadas, family CARP. So that just shows if you were to add all those together, they are by far the lion's share that primary care can do this via telehealth, and they can do almost all of their care via telehealth. And then you go down to some areas that surprised us, such as rheumatology. They've been very successful. Cardiology didn't even occur to me that they would be a good candidate for this. And neurology makes sense, but even neurology and some follow-ups. So, and hematology is one of those areas where we say we need patients to come in for cancer care. Well, actually, we need them to come in if they're going to be receiving treatment, but we actually don't want a patient with a compromised immune system coming into a clinic anyway, usually. And so, especially during a pandemic. Next slide. The title of this is wrong, and I apologize. What this really is meant to show what has been our adoption of fully integrated Zoom into the workflow, because I can measure that. And so you can see the dark green and the green, and that's over 3-week periods. And the dark green at the bottom, that's the My Chart, the patient portal integrated Zoom, which I know is secure. The light green is the other Zoom, which I don't think is very secure, but it's working and it's compliant right now. And so you can see that went from 28% a few weeks ago, where it's already down to 15% now. And then the yellow at the top, that's the everything else. That's if the doctor gave up and used Doximity, if they decided just to have a phone call. And this is another one of those key metrics I'd like to see the green beginning to increase, just because I feel that the value for a patient to have a video visit is greater than the value for a telephonic visit, but a telephonic visit is better than no visit. So next slide. These are another things we've seen bumps in. This is just the number of patients who've actually enrolled in our patient portal. And you can see that from February to March, when we were going live on our revenue cycle system, it increased because patients can pay their bills and see things online. But we've seen another spike. And so as of April, we have over 102,000, and today we're nearing 103,000. All right, next slide. And this is probably the most important slide in terms of evaluating what the impact of COVID has had on ambulatory care providers. And I think you could look at this in just about any geographic area of the United States, it'd be close to the same. So these are the average number of visits per week. Would you mind going back? So the average number of visits. So we normally see about 12,000 visits, and that green bar going across the top, that's that average. That's just the average number of visits we had coming through the clinic every week. You can see the week of 3/8 to 3/14, it began to drop a little bit. And then starting that next week on the 15th, it plummeted. We saw less than half of the normal visits in person, that's the dark blue, and the telehealth is that little blue box on top. We began to slowly begin to see more telehealth. And you can see that our in-person visits dropped in half again the next week, and that stayed about the same, but our telehealth visit volume has brought us above the 50th percentile. And the question is, how can we even stay open? And that's really a good question. And I wish I had a crystal ball. That we do know that we have enough finances, and we furloughed 50% of our staff have been reduced in terms of hours. 30% are completely furloughed. We just can't do that. But we do know if we can keep volumes about where they are now, we know we can stay open through October, which by then we think everything should be done. And we actually do think that telehealth is here to stay, and we're actually now investing in additional ways where we can modify schedules and safely bring patients back into the clinic and provide more space and time and distance between in-person visits to help make everybody safer. I think that is it. Oh, we're marketing now. That's the other thing. Is now we're beginning to let people know that we're open, because that's the other thing is people don't know how to access care. So we're now trying to reach out to people besides the people who are calling, letting them know that we actually do have capacity and we think it's a value if they find it to be a value.
Thank you, Sean. Before Dr. Williamson goes, I just want to remind people that please, if you have a question, put it in the Q&A box and not the chat box. So again, if you have a question, please put it in the Q&A box. Dr. Williamson?
Hi, thank you everyone for being here today, and thank you for having me on. So just to give a one-liner on kind of the different hats that I wear that all converge on telehealth. So I'm a general pediatrician, so I have been using telehealth for the last 5 weeks. I've also worked with Chalk Children's Hospital in the 5 weeks that we've been doing it, as well as the preparation for it. And I'm also, as AARP Orange County president, on a California statewide level, we're also looking at how are we going to get reimbursement for telehealth. So looking at it from multiple angles. So I think one thing that I'd like to point out that I think all of us are aware of, and you know, Ginger made an excellent point, is that telehealth is not new, right? I mean, telehealth has been used by some of my patients and it's been offered through some of their insurance companies, but telehealth is new for the majority of us because we just haven't even really thought about it, or if we thought about it, we didn't even know if reimbursement would happen. So for primary care physicians and specialty physicians, this is a rapid new increase. And you know, there's a few challenges that we've had in the last 5 weeks that I think all of us have had, which is first the technical challenges in creating a workflow that we've heard a little bit about. And there's also the ethical questions. And it'd be interesting if we have time at the end to see if that has come up in the conversations for those who've rolled out telehealth. I will say that for Chalk Children's Hospital, we just hit our 10,000 mark. So we just had our 10,000th telehealth visit in the last 5 weeks, which we're very proud of. So I do feel that we have gone from 0 to 110 in a very short period of time. And what we've kind of done is done this in phases, right? So there's quick push out, and now we're at the point where we're stepping back and evaluating how did that go and what can we do to make this better. I have one slide that I was going to show you guys, if you can go to the next slide. This is, we have a number of different documents, but I think this one is really sort of telling where our brains have been as pediatricians in terms of how to have a successful virtual physical exam. Because I think one of the biggest things is thinking about what's better as an in-office visit versus telehealth. So just because we can do telehealth and just because it is now more readily available and we're starting to get reimbursement for it, fortunately, that doesn't necessarily mean that it's going to lend itself to the best visit. And first and foremost, we always have to think, what are best practices? How are we going to deliver the highest quality of care? And this is something that we've talked about in our hospital multiple times, because we've had a number of physicians who are not comfortable with telehealth because we can't shut kids' ears, we can't listen to their heart, we don't know if they have a murmur. And even if it's a kid who we've been following for years, if they have a fever, that this could be myocarditis, right? So there are definite limitations. But then I think on the flip side, being able to offer telehealth as that primary care provider who's seen that kid for 5 years, we're much more likely to have a successful telehealth visit because we know that family. So this document here goes over some of the key things about how to ensure we have a successful virtual physical exam. And we have a number of other documents on our website as well that we can share with you afterwards. So for me, when I think about telehealth visits, I kind of boil it down into 3 types of visits in my mind. So there's the current rule out COVID-19 visits. So those are the kids that we'd like them to stay at home and not expose others if they have fevers and respiratory symptoms. And there's limitations there with doing the telehealth visit because we want to make sure they don't just look fine and we reassure them and then they actually end up getting really sick. But we can kind of triage. Is that a kid that we need to bring in and do COVID-19 testing, or they're in a good age bracket, parents are really reliable, they clearly don't have any respiratory distress, we can keep them home. So that first type of visit is something that it's for here and unfortunately for a while until COVID-19 starts ebbing away. But for the long term, I don't think that's going to be the biggest of the telehealth visits that we see. I think the next category is acute visits that are non-respiratory. So that's things like rashes and a lot of preventive care and talking about mental health and anxiety. And I'm finding that that's an increased number of telehealth visits that we're seeing is actually those visits. I'm doing a number of my ADHD appointments with, because we usually do a mid-year check on their medications or if we do any medication changes. And those are pretty easy to do because we can have the patient potentially get a blood pressure check at home and check their weight. And I know that family well, right? So that lends itself really well to telehealth. And then the third bucket is well visits. And this is something that there's so many pros and cons to doing a well visit for a kid or really for anyone as telehealth. One of the biggest challenges is reimbursement. So right now, I think that most states, and you guys may know better than I do, are reimbursing for sick visits as far as we can tell, right? We're still kind of early and we're still kind of seeing those numbers come in, but well visits is really tough. And I think the ethical question for well visits is well placed because can you truly have the same kind of interaction and do all appropriate blood pressure, height and weight, and any point of care testing when kids are at home? You can do some of that, but not all of that. So I think that's really the next challenge that we need to talk about. In terms of long term, and Ginger, I really appreciated your comment on, I think ultimately this is going to come down to reimbursement, right? Telehealth we've talked about for so long, and the reason that we've been able to have all of our primary care doctors really nationwide, as well as specialists, hop on board is because there's this massive need, and insurance companies are finally saying, okay, all right, so you need it, we'll reimburse it for you because we know that kids and adults have to stay at home. So how long is that going to last? And are we going to be able to come back now to insurance companies and say, we can provide good care with telehealth? I think that's going to take concerted effort from all of us here on the panel, through legislation. That's the only way that we're going to make a change. And at the same time, we also need to think about, let's not get too excited about telehealth in the sense that we also need to make sure we're providing always the best quality of care. So if the visit is better done in the office for whatever reason, and we're not talking about a 4-hour car ride, right? Then we can start, thinking about maybe this would lend itself better to an in-office visit. So we can't lose that vision as we're moving forward. And that's really all I had to say.
Okay,
Thank you so
thank you. Thank you, Dr. Williamson. Before we move on to Dr. Humphries, there was a quick question for you. Somebody asked if they could use your checklist down sheet that you were just showing, the guide.
Absolutely.
Okay.
Yes, we have it on our Chalk Children's website as well as our AAP Orange County website, so we can make sure I guess get that up.
Okay, great. Thank you. And we'll make sure that people have the links to all the resources you guys all the panelists are providing. Okay, perfect. Dr. Humphries.
I'm going to take just a few minutes to talk about specialty surveys or services and how we really triage for urgent issues, because that's one of the most important things. So there are a lot of good reasons to expand telemedicine. And for us, really, we were wanting to minimize patient exposure. My profession and my field does have elderly patients, and so there's a concern there for those patients. But we quickly needed to develop a system for which we could determine what to do with the categories of patients we had. Post-operative patients, surveillance patients, chronic patients, which we've talked about, and also new patients, and really focus on triage. And that's what I'm going to talk about in just a minute. But the nice thing about telemedicine, and this was touched on by Sean, is it allows you to keep yourself and your staff working, which gives you a revenue stream and really provides quality of care to everywhere. And that's what this slide is about. So in my field, I am in a central area where a number of those dots are aggregated in Sacramento. And so this map represents all of the vascular surgeons in the California area outside of the San Francisco Bay Area, mind you. And what you can see is there is a broad area here, and there are not a lot of dots that are on here. So we actually have vascular deserts, just like there are food deserts, there are specialty deserts throughout the system. So how do we bring care to patients in this vast majority, or in these very broad areas? And that's what got me started in telemedicine, was looking at this particular kind of a problem. So I want to just touch on who to see when and how to triage, because this is what we are doing with new patients. There are many patients that you will get a referral on who are highly anxious about their problem. I deal with a lot of life and limb-threatening issues, but some of those things that people think are life or limb-threatening are actually a chronic problem that they have had for a long time. So we are using telemedicine in 3 different ways. For patients that have a non-urgent condition, but yet those patients are very concerned, fear of having a stroke, fear of limb loss, we are seeing those patients and offering them some comfort through telemedicine, and then scheduling them in the phase 3 reopening. If you haven't had a chance to take a look at the recommendations for how to open up America, there's a website that can be found at. And in phase 3, you have routine care for vulnerable populations. So in our practice, what we are doing right now is really triaging these patients that don't have urgent issues, but the patient feels that it is highly anxiety provoking for them. We are seeing patients with urgent needs. When we see these patients that maybe have a limb-threatening condition, we can also help those patients get scheduled now, and we can assess them for COVID symptoms that would potentially lead us to change our methods. We're fortunate where I am at to do all of preoperative testing on all patients that need to have a procedure, but that's not necessarily the case at all institutions. So if you can see a patient that really does need a procedure now, kind of find out what their symptoms are, you can also rationalize whether to do it today, do it in a week, preoperatively test them for COVID, and how to, if you cannot test them, appropriately cover your staff and your team to protect them from the virus. The final thing that we're doing is we're also using it for patients with intermediate needs. Those patients can likely wait until the phase 2 reopening, and so we're doing telemedicine now, but expecting those patients to realize that they will get a call in 4 to 6 weeks so that they can come back in. Because not all patients can have their procedure scheduled without being seen in an in-person visit. One of the questions that had come up during this talk is what platforms to use and how to integrate it. So it was discussed about using the Zoom platforms, but that's not an option for everybody. Doc.C.me is a platform that's actually free and is HIPAA compliant. Not all facilities are able to use it. There is an upgrade for it so that you can have more of a protected encryption, but it is a free HIPAA compliant platform. There are multiple other platforms. Some of them are not HIPAA compliant and some of them are. Right now there is a waiver, but it is still important to remember that HIPAA regulations are regulated at the state level. And so you have to be very cautious about what you are using. I would say that if you want to use some of these, to investigate it just a little bit more. And then of course we had to do a lot of work in terms of coordinating billing, which the coalition has a number of fact sheets that you can use for billing, which are really nice. And I would encourage you to use some of these because the billing is not easy. If you're looking at Medicare, if you're looking at Medi-Cal or Medicaid, or if you're looking at private insurances. So there are some nuances there that we can provide more information for. And the final thing that I'm going to really kind of focus on is the specialty needs that we need going forward. So a lot of people have talked about the uncertainty that's to come, but more than just the uncertainty in the reimbursement, there are some key areas that need to be addressed in order for telemedicine to become mainstream. Ginger talked about her daughter gets a CT scan and then she meets with a provider in order to go over that CT scan. What we really need is seamless transition of those images through a cloud-based system. So that if Ginger's daughter gets her CT scan in Northern California near Oregon, it can be transmitted instantly down to a main hospital that can look at that. We need increased provider willingness to do telemedicine, specifically in rural areas. And that can't just be reimbursement driven. There are a lot of time constraints that go into doing telemedicine, and allowing a nurse or having a nurse that could help facilitate that in these rural areas, or even just acting as a hub for patients to get good internet access is important. More than ever, we need improved electronic medical record sharing and the ability to speak to medical records seamlessly. When a patient that has 20 medicines comes to see me and they say, oh, my medicines are in the chart. Well, your chart is actually at a different hospital system. So it's not in the chart here. Those are areas that need to be focused on. And finally, we need better broadband access in rural areas so these patients can actually be seen through a visit that is of good quality. So there's a lot that I put out there, and we'd be happy to talk about some of these in the Q&A.
Great. Thank you, Dr. Humphries, and thank you to all of our panelists. I'm going to turn it over now to Timmy Leslie to go ahead and moderate the Q&A. Timmy, are you on the line? You might be on mute, Timmy.
Hi, can you hear me?
There you are. Yes, we can.
Great, thank you. Like all good things of telehealth and video visits, my Zoom crashed during the middle of this. So here I am, I'm back. But I just want to thank all of our panelists for such fabulous discussion and also insights. And welcome all of you to be able to submit your questions through the Q&A function. And one of the questions that just came through that I think we can look to Dr. Williams, if you would be able to answer this, is how do we think about over-the-counter tests and other types of supportive peripherals that may need to be at the home to be able to get the best quality visit as possible? Have you had experience in that?
So we haven't had any patients do tests specifically at the home. We've had them do vitals, so weight, height, and blood pressure. But I think that is definitely sort of a next step for a lot of patients, you know, kind of in the way that a patient with diabetes would be able to do a blood sugar test at home. I think it's always good, though, to think about what needs to be done for the test to be implemented. So if it's a urine sample or a finger prick, that's pretty easy for the patient to do. But there's going to be some limitations for, you know, if a strep swab would ever become available for the home, the likelihood of having a high sensitivity specificity on that would be probably pretty low because the patient's not going to want to get a good swab or really know how to do that. So I think that would be the mindset moving forward. But I think it's definitely something we should think about for particularly for patients who have chronic illnesses, and how to incorporate that into a telehealth visit.
And just to follow up, has any of our panelists had an experience with patients taking their blood pressure? Do you give them any guidance on how best to do that, or the tools that they should be, like the cuffs that you'd recommend? Dr. Williamson, do you have that?
We don't have anything specific other than phone guidance, but you're putting a to-do list in my head of how it would be really great to have that be something that's actually written in on our website. You know, how do you get a good blood pressure at home? One thing I often tell patients, because oftentimes the automatic cuffs are not the most reliable, is I tell them to do 3 of them. So that way, if there's one wonky outlier, it doesn't get me too concerned.
Wonderful. And Sean, do you have experience with helping your providers on how they're thinking about the vitals?
Yeah, what we're just now exploring rolling out some new visit types. So for annual wellness visits and others, and for most, we're not giving them the equipment. A lot of the people who are concerned about their blood pressure already have figured out mechanisms and devices that work from home. We just indicate in the comments that it's self-reported and not of anything that we can control. But it does usually, if you have prior information that you can trend it against, it does give you a lot of valuable information that could be beneficial. We're just waiting to see if the regulators are going to allow that to be used as an official blood pressure for quality measure purposes.
And May, do you want to address the question around billing and the ability to be able to have the billing codes for telehealth visits? And I know that there's a lot of references on our site as well.
There are, and also keep in mind, and Dr. Humphries touched upon this, it's also going to depend on what payer you're trying to get the reimbursement from. So it's going to vary in how they do things. So Medicare will vary from like Medicaid, where if you're talking about Medicaid, it'll vary from state to state. And then when you're talking about health plans, it'll vary there. So you can check the CCHP website, the coalition website, but also a lot of these government agencies such as Medicare and Medicare have also put out really good guidances as well as far as what their policies are during this COVID-19 emergency process. So if you are talking about a private payer, get in touch with that health plan and ask them exactly what their policies are regarding it, because again, they vary from plan to plan and payer to payer. So depending on who you're looking for, go to them first. You can find some of the information on CCHP's website and the coalition's website as well.
And then we also have a question that came in. Again, this is, I think, around a few questions around supporting colleges and universities. And I'm assuming that this is how best to support the students that are either potentially on campus or not on campus, depending on their campus closure rules. I'm going to throw this one over to Dr. Humphries, just because of the UC Davis connection. But do you have any recommendations on the school side, or we can always do a follow-up? But thought you might have some thoughts there.
Well, we've been fortunate, of course, that we have video visits that are very integrated into our health system already. But if you're looking at a large institution that doesn't necessarily have that, I would say that almost all providers are being able to perform video visits. So if you look at the waiver, the personnel is not specifically changed. You need a nurse practitioner, you need a physician, and there are very specific requirements about who's able to perform video visits, but most of those would be the people that are running some of these student-run clinics. And so they should be allowed, nurse practitioners are allowed to provide telemedicine care. Again, using a platform, I mentioned Zoom is a platform. You want to be very specific when you're using Zoom, that you create individual IDs, that you use the virtual waiting room, which is a very nice feature for using these things, so that when a patient comes to your virtual waiting room, they can't run into another patient's visit. That's what some of these platforms, DocC.me, have. You're put into this waiting room. You have a password for each of those. So getting yourself up and running with those is not terribly challenging. And then using the billing codes on the back end specific to the different providers, I think is where you need to do that. And then of course, documenting in your own electronic medical record or whatever medical record.
Timmy, regarding that, because I have spoken to some of these student health programs, another area where they may be running into issues for, because a lot of the students have gone home, is the licensing issue as well, with like their students returning home and assuming like they have multiple states that these students are coming from.
Mm-hmm. A good point. And I'd also highlight, and we can do this offline and follow up of the additional webinars that the coalition will be hosting that'll be addressing school-based programs, and we can look at higher ed as well. So we can follow up there and highlight subject matter expertise. May, there's also a question around licensure and providers being able to provide care across state borders. Is that something you want to address?
Yeah, again, that's going to depend on what state you're trying to provide that service into. And also, one thing, because I did see a question in there that was involving a nurse practitioner too, it may also depend on your profession. So rule of thumb essentially is the states control licensure. In pre-COVID-19, it was essentially, the states were saying you need to be licensed, except for like some very, extenuating circumstances or situations. With COVID-19, you see a little bit of loosening of that, but mainly like examples such as in the Medicaid program, allowing like a person who's licensed in another state to be able to provide some services in the Medicaid program. You'll see a little bit of relaxation of that, but not all states are doing that. The other exception that is there, depending on your profession, might be a licensure compact that exists. So there is a nurse licensure compact, but in order for that to work, where you essentially have one license and can practice in multiple states, those states involved need to be in that compact. So if this question is being put forward by somebody who is a California licensed practitioner, know that California is not a member of any of the compacts that exist out there. So that compact exception is not going to apply to you. And then depending on your profession and depending on what states that you're trying to provide a service to a patient, it depends on what that state has said about licensure and if they've relaxed some of those rules during this emergency period.
Wonderful. Are there any other questions?
Timmy, I saw one question in there actually real quick about workflow, and I think that's really important. Sean mentioned a little bit of this, but one of the main things that you have to do when you're starting this, we've had a group that did no telemedicine. You have to retrain your office staff and help with the workflow. And that's not intuitive. So the person that was just doing scheduling before is now become your Zoom expert. And you need to get the patients on board. So I think the workflow is really just about reusing some of the people that are in your office and repurposing them. But that can be done with a little bit of flexibility. I wasn't sure if that question got answered.
Thank you so much for addressing the workflow. And I think that that this will be an ongoing discussion, and we will be able to track and disseminate different example workflows as Dr. Williamson presented as well. So I think that is a great role for the coalition going forward, and we can be a resource for that. Thank you.
I was just going to add one more thing. One of the workflows I'm currently working on, it's in draft form, but we've already started doing it, is how to convert on-call calls, so evenings and weekends, into a telehealth visit on the fly. I've done this a couple of times myself and tested it through billing at our hospital, and it works just fine. But again, you need to create a workflow that works for everyone who may not be the most savvy with how to do it.
Mm-hmm.
So that should hopefully be coming up shortly, next couple weeks.
That's a great point.
I actually have a question for the panelists, and maybe it's more for Julie and Ginger as well. But there have actually been a lot of questions coming in like how do you better educate the consumer on like selecting when to use telehealth, or how to even find telehealth. And all of you guys have been doing wonderful work. Happy to see the effort that you've taken in like educating the consumer. Sean, your whole thing of having the prep calls was terrific. But what are some of the steps that can be taken in order to inform them a bit better about telehealth and that this is an option?
Well, I'll start only because we have almost 40 million members and we're educating them all the time. And so we are sharing information with our members via multiple platforms. So they're receiving information from our magazine and our bulletin, which are actual paper copies that arrive in their mailbox. We're informing them through multiple resources on the AARP.org website. We're educating them through these weekly town halls that we're having, which are averaging anywhere from 80 to 200,000 people on a call at a time. And so we have a very large breadth way to touch our members in regards to the changes that are happening in response to COVID-19. The flyer or the postcard that the individual office sends to their patients that says this is an option is a huge information gift to the potential person, because most people, unless you have had need of telehealth before now, don't even really know what telehealth is unless they have possibly had an email exchange with a physician before now. So good old-fashioned mail is a way to go.
I probably, because I've used it prior, I did not know it was an option until my doctor at UC Davis offered it to me, and I appreciated that very much. I run a Facebook page for CCS families, all partnership for the top North 14 counties. So I try to advertise on there. I have put that link up, information up for families, but due to a health summit being canceled due to COVID-19, that information has not spread across California as rapidly as we have liked to get them into that group so that we can help them along this path. Probably by mail, it'd be the best way to notify those in my circle. The doctor's offices here have put out some links in our local area. My mom did a telehealth yesterday. She had to come to my house to use my Wi-Fi, but she was able to do that and get a little technical assistance in her age. So the local hospitals are putting out some stuff here saying that the telehealth is available. I don't know the best way to get it out, but I've been plugging it away all that I can. I've called some people and told them that it was a viable option now, especially since the COVID started, that the insurance companies were allowing it. And that's the best I can do, I think.
I was going to add in there, I think social media is something that, we have to think about where our patients, and for pediatrics, patients' parents live, right? So when I'm thinking about young families, they live on social media. So our website, social media, and then we also have a way that we can do a texting. It's called Call 'em All. So we can do a mass texting in chunks at a time with, you only have so many characters, but you can put in there new hours and the fact that we're doing telehealth.
That's great.
That's great. And Dr. Williamson, there's another question that came in to you specifically around pediatrics, and how are you engaging the parents, and what role do they have? And I guess, are there limits to their role? And are you asking them to help with any of the exam itself?
Yes, so it really depends on the age of the child, right? So a teenager would be very different. So addressing a young child, I would do it just the way I would in the office. And at the onset of all telehealth appointments, and I'm making the assumption that we're all doing this, is that you first have to get verbal consent. So even though they've signed up for telehealth, we use Zoom, you get your PMI number, they get on. The first thing that I say is, are you okay to go ahead and continue on the telehealth visit? I get their consent, and then I get the history. And then when that's completely done, we divert the attention to the child, and sometimes the child has an address, whatever it is, right? For a teenager, it's a little bit more difficult. And we are not doing sensitive exams on teenagers just because we don't feel comfortable, and we don't want the teenager to feel uncomfortable with that type of media, looking, at their sensitive parts. And so we bring them in for those types of visits. But in talking with our mental health teams, a lot of what they've done when we need to keep those conversations at least private is we still have the parent know that we're having that discussion with the child, just like we would if they came into the office. We start with the parent and the teen. We'd ask the parent to leave. We'd have that secure conversation with the teen. So we just try to replicate it as much as possible. And we'll have the teen put in earbuds so that child can hear us. And we have as much of a private conversation as we can. So hopefully that kind of answers the question.
Wonderful, thank you. And this question is for our providers. How do you go about reading your consent forms, or do you send it to them before, or is it, I guess, integrated into the visit itself? Dr. Humphries?
So for Epic, that's integrated, and they have to fill that out beforehand. But I have other clinics that I see patients in, and I send them the form, they sign it, and then they either take a picture and send it back, and then I scan it into our medical record. So there's that way to communicate it. You can use other platforms to send text messages, so you're not sending it from your phone necessarily, if that would be better. You can specifically, Doximetry has that ability. And so you can send that to them. They can sign it themselves, and then they just send it back to you. That.
Wonderful. And Dr. Williamson, do you have any words of wisdom there?
So we are currently working on getting COAs as part of the workflow, which need to be signed every, that's not per visit, but that's per year. And on top of that, we're doing it verbally, just on the call, and then making sure to document that within the note, with each creation of a note.
Wonderful. Well, I will promise to all of you that the questions are fantastic, and we will do our best to answer them in writing as well, and put that on our website. So if we didn't get to your question, we'll do that offline. I'm going to hand it back to you, May, to wrap up.
Well, I just really wanted to thank our fabulous panel today, our speakers, and they were truly wonderful. And like I said, you have a bunch of smart people talking to you today. So thank you all for your time. Thank you also for our attendees for being on this webinar. Thank you especially to the sponsors again, the California Healthcare Foundation, AARP California, and the National Consortium of Telehealth Resource Center. For the recording, the link to the recording that will be up in a couple hours, no later than 24 hours, you can go to the Coalition webpage on the CCHP website to access that. Thank you also to Blue Path Health for helping put together this webinar and assisting with the Coalition. And thank you also to the Telehealth Policy Coalition of California for your support and continued work of the members on behalf of everybody where telehealth is concerned in California. So thank you again. And I hope attendees that you enjoyed this webinar know that we will be holding more webinars in the future. So keep your eye out for the notices, and we hope to see you again. Thank you.
Thank you.
Bye, everyone.
Thank you.